Hello and welcome to the February RIV call on screening. Today's speakers are Esther Latres, Ph.D., Raquel Lopez-Diez, Ph.D., and Anastasia Albanese-O'Neill, Ph.D.
Thank you and welcome to the RIV screening. My name is Esther Latres and I will start in presenting our strategy, the research priorities, and the recent progress updates. But then I will let Raquel Lopez-Diez, who's the new lead of the screening portfolio, talk about one of the exciting projects that we have ongoing. So in the future, you will interact much more with Raquel, and you will hear much about the progress from her. And then Anastasia will talk about all the T1D education and the clinical implementation that she and her team been working on. So today we'll talk about screening. So the three pillars at the top is our cures big portfolio. One of the goals lately for the last few years has been to focus on how these three projects or pillars interact with each other. It's important to emphasize that obviously we follow our mission to define our strategy and priorities, but also we focus on advancing these therapies at all stages of type 1 diabetes. And today we're going to focus on the very early stages of type 1 diabetes that we've referred to as pre-symptomatic. So it's mostly before the clinical diagnosis. Just to remind you that this is modifying therapies involved all the work that's been done on new immunotherapies and also beta cell regeneration. That covers mostly the new onset stage. And then the cell therapy that you've also been hearing about that covers the established people living with type 1 diabetes, and mostly on providing highly functional cells that can replace the loss of functional beta cells and provide glucose control. Obviously, the improving lives is all improving the lives of people living with type 1, and our screening also involves as many other priorities and portfolios at JDRF, training researchers, and for this program specifically, clinicians. So I mentioned the mission, but also the vision is our vision is a world without type 1 diabetes, and that includes the many different pillars of the cures, even the ones that are at the very early stages. So we talked about cell replacement therapies that will help people living with type 1 diabetes, but we're focusing on early stage, again, of diabetes that will help people that is still been not diagnosed or are in the process of being diagnosed. So this screening program, it's part of our vision of a world without type 1 diabetes. Screening is a project that it also aligns very well with this pipeline that follows many of the other project areas. So we do have a lot of the discovery research that moves into regulatory approval. Some of the antibody assays that I'm going to talk about are important, and transition through this pipeline. Healthcare coverage, we're not going to talk a lot about, but research has been key in providing, obviously, all that's been enabled in order to provide healthcare or make a statement in providing research for adopting screening into healthcare coverage. And also Anastasia will talk about all the clinical adoption. So just to bring a little bit about the history, so we've been talking and working on screening for a long time. And in the past, most of the focus and the priorities have been on providing evidence for screening. What is the feasibility of screening programs or screening very early stages of type 1? The ability to predict disease progression, this has been key. This is coming from JDRF, obviously, some other funding organizations that have been helping screening, but being able to provide a staging of type 1 from very early to the established, I think this has been a great achievement. And most importantly, what are the benefits of screening? Obviously, we believe there are all the benefits, so we keep working and pushing for screening programs. Some of the benefits that we talked about and it's been demonstrated is preventing TKA, mostly at diagnosis. It's also providing a benefit in the time to plan and prepare in this population that have started developing type 1 diabetes at the pre-symptomatic stages. And most importantly is the potential to participate in research, clinical trials, at identifying therapies to delay and prevent type 1. So that's the only way to find individuals at risk is obviously through screening. But today, what we're focusing on and moving forward is expanding from research settings into clinical practice. The access, very important. How do we generate and expand screening by providing clinical guidelines? How do we move towards adoption by healthcare system? What's the data? What this healthcare system needs to provide screening and to be convinced that screening provides benefits? And the third one is identifying more people at risk who can benefit from therapies. And obviously there is one therapy now that's approved for stage 2, teplizumab. So again, we'll focus on the research pillar, but I just wanted to provide that the other 2 pillars are screening are very, they go head to head to, which is the health policy and the education and clinical implementation. So, so type 1 diabetes develops through, or the autoimmune process develops through different stages, and it develops way before it's diagnosed and way before an individual becomes insulin dependent. This is what we call as pre-symptomatic stages of type 1. And there are many different factors that are involved. And we talked about in the, for a long time, we talked about microbiome, viral, but there is genetic susceptibility. There's a family history, and I'll talk a little bit more about what this genetic susceptibility is. The most, I think, critical part of all the progression is being the statement that presence of islet autoantibody predict progression to type 1. So this is where I'll talk a little bit about islet antibodies, but also changes in glucose levels. So this is the progression that we're following through the type 1. And at the bottom part is there's these little cartoons that are supposed to be part of or an islet, a human islet, and in the orange represents a beta cell, and as you can see, they've been lost through the progression. So by the time at the diagnosis, there are very few, or there's definitely a loss of beta cells, but it's still important to keep these cells, as I'm going to mention in the past. But obviously what we're trying, or at least what we're trying to do, is to delay or stop the decline of the loss of beta cells. So why I focus on genetic susceptibility and islet autoantibodies and changes in glucose levels is because they've been used, or they can be used, to identify and monitor in early stages. So the expression of alleles associated with T1D risk has provided a genetic risk score that can be used. It's still the presence of these high risk alleles. It's not predicts type 1, which still needs to present a risk, but it's very low. But still, it involves what we call this HLA, or these are important molecules and genes that determine self versus non-self. And that's also been important in clinical trials, as some of this genetic susceptibility or HLA alleles can predict maybe a response to a therapy. So the second is the islet autoantibody. So this indicates that immune-mediated activation and beta cell damage has started. There are now 4 autoantibodies. And lastly, how can we detect changes in glucose levels? So once these changes in glucose levels have manifest, indicates that there is an impairment in glucose response and insulin secretion. So if we go back to the cartoon, that the loss of these beta cells is now not enough to fully maintain a glucose control. And that can be measured in different ways: oral glucose tolerance test, mixed meal tolerance test, glucose, HbA1c, and also continuous glucose monitors can be used to determine these changes in glucose levels at the very early stages. So being able to stage type 1 with autoantibodies in changes in glucose levels has allowed a staging of type 1, which is really important. So the definition of the stage 1 is when normal blood glucose is normal, but there's the presence of multiple autoantibodies. A stage 2 is defined when the abnormal blood sugars are manifested, and there's the presence of 2 autoantibodies. And the stage 3 is the clinical diagnosis of type 1. It's basically the step of insulin dependence. So there is not enough beta cells or insulin production to maintain glucose control. And then the established type 1 is where full insulin dependence is reached. So we talked about C-peptide a lot, and we talked about how can we monitor beta cell function. This is key, whether it is in the pre-symptomatic stages, whether it's in the new onset, or whether it is in the islet transplant setting. How do we measure beta cell function? So it's a validated biomarker. So before I go into that, I just want to briefly describe what C-peptide, because we talk about C-peptide a lot. So in beta cells, which is this cartoon at the left side, that's the pancreas, an islet, and then it's meant to represent a beta cell. They make insulin as a precursor that's called proinsulin. And this proinsulin, it breaks down into 2 major parts. One is the active insulin, which is the chain A and B. That's the active that will obviously signal through the cells and induce glucose response. But then there is this fragment here, which is the C-peptide, that also is produced, and it's stable and it circulates. So it's what we call a biomarker of beta cell function, and it's been accepted as a marker for beta cell function. So why do we measure C-peptide, and why is it so important? So I would emphasize the need in these pre-symptomatic stages as important to look at the decline of the beta cells, how close an individual is to achieve the stage 3. But it's also very important in the new onset. So the beta cells of individuals recently diagnosed with T1D, they still produce insulin. As I mentioned, it's not enough, but they're still there. And they are important because they're in the pancreas, they're in the islet, they're next to other cell types that I didn't talk about, but there's cells that what we call alpha cells that produce glucagon that are very important to measure hypoglycemia. So these cells are in where they should be, which is in the pancreas. Their physiological signaling, which is mostly very different than when insulin is administered through the skin. So most of the insulin in the pancreas goes into the liver. So these remaining beta cells, they're still functioning as beta cells. So they are important. And we believe that maintaining this C-peptide or beta cells in the new onset, which is the stage 3, it is important, and it can provide clinical benefits later in type 1 diabetes on hypoglycemia, or maybe some disease complications. So that's why a lot of the clinical trials are focused on maintaining C-peptide. And one way of measuring, why we're measuring C-peptide and not insulin in the new onset. So as you can see in this cartoon, so in the new onset of individuals that are diagnosed that they need exogenous insulins, we have the insulin that comes from the skin, and obviously the insulin that comes from the pancreas. So we could not distinguish if the insulin comes from the pancreas or comes from the skin. But when we measure C-peptide, this is a measure of how much insulin the beta cells make. So just to provide some of the research priorities, it's expanding access to screening with a lot of the programs that we have with support infrastructure and expansion of screening efforts. Implementing science, it's a way, obviously, the only way to increase trial recruitment and access to disease-modifying therapies. We need to improve the efficacy of staging and the diagnosis of at-risk population, both in pediatrics and adults. We are improving glycemic biomarkers of disease progression as they transition from stages 1 and 2 to clinical diagnosis. Also, the third priority is to improve the risk assessment. Can we improve or implement a genetic risk score, but also improving performance of clinical laboratory assays, antibody assays? And I'll mention and talk about how important it is to collate data to support and enable healthcare system adoption. So a lot of the work that goes into guidelines come from research and data that's been generated. So quickly, I'll mention that the strategy of expanding access has changed while we worked on familial first relative screening. We need to recognize that 80% of the people with new diagnosis had no family history. So these are some of the programs that JDRF has been working on expanding the global population. Some of them are in newborns, some of them are in children and adults. Some of them include the genetic risk score and genetic sequencing. Some of them only include antibodies, and some others include both islet autoantibodies and genetic screen. I'll also mention that our screening strategy has changed, and it is been focusing on adults as well. The data shows that up to 40% of adults diagnosed with type 1 are older than 30 years. And many of them has been misdiagnosed with type 1. So I think it's a focus, and I'll show an example of how we are addressing this priority. And obviously, why are we expanding access to screening is to increase the number of clinical trials and access to disease-modifying therapies. So you've seen the presentation of the disease-modifying therapies, and we are obviously very pleased to see all these clinical trials that are in the new onset. Look at the list under stage 3, how many there are, but there are not that many in stage 1 and 2, right? So again, a screening will be the only way to identify these individuals and test the therapies that are being developed in the space, or maybe we can use some of the stage 3 therapies into earlier stages, like a stage 2. And I underline here teplizumab as one of the first therapy in stage 2 that delays the onset. So moving on to the priority number 2 is to improve the efficiency of staging and monitoring. So what I represent here at the top is the familial screening and the flow that most of the programs have been following, which obviously is autoantibodies. That's when the presence of autoantibodies is the main prognosis of type 1, and followed by the clinical and glucose metrics. But if we go to the global population and we expand into global population, there may be other opportunities. Obviously, the presence of autoantibodies and moving into clinical, the blood glucose metrics will be followed and implemented, but there may be other opportunities. Could we start with maybe the genetic susceptibility? Are there database, or are there ways that this genetic susceptibility can narrow down some of the individuals that may benefit for a follow-up autoantibody test and glucose metrics? Or there are so many now clinical records, and there's machine learning technologies that maybe we could use to narrow down the population that maybe shows some symptoms of type 1 diabetes and can narrow down for a test of autoantibodies. So this is mostly opportunistic, and on the clinical records, I will show an example. This is for type 1 people with type 1 diabetes that they've been diagnosed with type 2. The priority number 3 is improved risk assessment tools. So we are working on improving the islet autoantibodies technologies. And as I mentioned, some of the risk score, narrowing down the genetic risk score and providing a risk score that's more, that can align with the progression. And glycemic monitoring that Raquel will talk about. And lastly is collect the data from screening research programs. As you can imagine, but that with all the funding and the research that JDRF has been funding, there is a lot of data. Lots of data. So for example, this is one example where academia and industry comes together. This case was an initiative from IBM that applied machine learning to type 1 diabetes. And that was a very large perspective. We followed T1D cohort and 24,000 subjects. And this is another thing that I want to emphasize about JDRF is bringing some of the programs that I mentioned before in those little boxes. They all work together and they all collect the data. So I think this is something that very important that JDRF brings. And what's coming from, or what came from this machine learning approach is that the number of islet autoantibodies, but also the combination of these antibodies can predict the risk. Also the levels of antibodies, not only the presence, but the levels, how high the circulating antibody levels can be included and used in improving the T1D risk. The distinct trajectories in progression, not all individuals progress the same way. Like at stage 3, sometimes we're asked how many beta cells are left, or what's the C-peptide threshold. It's not the same, and there is a different trajectories of people at the time of insulin dependence and stage 3. That bringing all this data has helped identify also the progression of the C-peptide or beta cell loss after the diagnosis can change. The trajectory is different. Some individuals can decline very fast, some others not. So there is different trajectories that this data has helped identify. And then importantly, what's the best age for screening? What's the best time to screen? So all this data put together show that the higher, probably the best time to screen was at age 2 and 6. And I've been talking about the priorities and the strategy, but I'm just going to give you a couple of examples of how do we, what kind of projects do we select to address this strategy and priorities. So one of them is this RTI International. This is a newborn screening project in North Carolina, which the study screens for childhood onset genetic conditions using genome sequencing. So it involves a lot of monogenic diseases, muscular dystrophy, spinal muscular atrophy, and others. These are monogenic diseases that different genetic studies try to detect. But clearly, this is, I want to make clear, it's an implementation and feasibility study. It's not to identify which babies are going to be at risk, but it's mostly identifying, learning about how parents respond to a risk of type 1 diabetes genetic score, for example. So they're asked about, would you like to know about type 1 diabetes risk? And a lot of the baby's parents accept it. And if they accept, then they get tested and they have access to educational information on risk and monitoring for onset. So this is, again, is an opportunity to bring T1 genetic risk to newborn. And so the plan is to screen up to 5,000 newborns and then validate this genetic screen. The second example that I'm going to present that's been aligned with our strategies and our priorities, it's what's called IQVIA, adult T1 detection. This addresses that diagnosis of adult onset type 1 is challenging. As I mentioned, 40% of adult onset type 1 are misdiagnosed with type 2. And a shorter time to diagnosis means that individuals get access to T1D management and treatment sooner. Sometimes it takes 2 years to diagnose diabetic with type 1, an adult. So the main application of AI is to use machine learning algorithms in pre-existing population-based health record. So the main goal of the IQVIA was to develop an adult T1D detection algorithm. It covered 800 ambulatory practices and over 750,000 individuals with type 2 diabetes. And what the project is and what the algorithm is just taking all the individuals that have been diagnosed with type 2 diagnosis, that's the orange circle in the middle, and then go back 2 years and then look forward 2 years after they were diagnosed with type 2. After 3 years, some of these individuals diagnosed with type 2 were confirmed type 2 according to their medical records, and some others received a type 1 diagnosis. So what this algorithm is doing is just taking all the data that's been included in these medical records, again, family history, laboratory tests, and many other things, and they're building this algorithm to, moving forward, prevent this misdiagnosis of type 1. So this algorithm was advanced to 2 healthcare systems to be tested and validated. So I'm gonna now let Raquel to talk about this exciting RFA that she's leading. So Raquel.
Hi, everyone. Thank you, Esther. I'm very happy and very excited to be here and explaining this opportunity. First of all, my name is Raquel Lopez-Diez. I just started JDRF a few months ago. I'm part of the research team and I'm leading the screening portfolio. So very excited to bring this opportunity. We're launching an RFA that is based on glycemic and beta cell monitoring of presymptomatic individuals. As you know, this is important for disease-modifying therapies and how to identify those individuals earlier on and how to understand when they transition from presymptomatic states to clinical diagnosis. So the main goal of the RFA is to improve the biomarkers, the glycemic biomarkers, to identify that transition. As many of you know, the current methods that are being used for this purpose are oral glucose tolerance tests or mixed meal tolerance tests, but these tests are time-consuming and it takes about 3 to 4 hours in clinic and especially challenging for the younger kids. So we're looking for alternatives to alternative technologies to identify that transition. And we will be looking forward to receive proposals with CGM approaches that can be done at home for a week, or a beta cell function with measurements such as C-peptides in those presymptomatic stages. With this all, we're aiming to fund between 3 to 5 group projects that are around $2 to $3 million. And happy to take any questions afterwards. Happy to bring it back to Esther for the follow-up of the screening portfolio. Thank you.
Thank you, Raquel. So in conclusion, what I've been trying to convey is that expanding clinical trials and access to approved disease-modifying therapies will happen only from the screening, and then trying to provide evidentiary research for clinical implementation of screening and monitoring. So supporting the tools for expanding and improving glycemic assessment in pre-symptomatic stages. I think we have so many tools. We have CGMs. We have so many other technology that we can use to validate these presymptomatic stages. Also work on validating a genetic risk score to expand global screening and being opportunistic, improving the adult type 1 diabetes detection. And most importantly, what Anastasia is going to talk about is supporting the design and validation of a clinical flow that will be required for adoption of screening and monitoring programs. Thank you.
Hi, everybody. First, I want to thank Esther and Raquel for that really excellent presentation. I'm Anastasia Albanese-O'Neill, and I'm going to talk about, I guess, what you would call the practical side of screening and early detection of type 1 diabetes. What is JDRF thinking about in terms of education and clinical implementation? So let's get off and running. I think many of you know I have a personal connection to type 1 diabetes. Our daughter Cassidy was diagnosed with type 1 diabetes in 2002. And I know this looks like clinical care, but I'm going to connect this to screening in just a moment. This was her prescribed, quote, technology, MPH and regular insulin, injected via syringe, a meter that conveniently could give a 7, 14, and 30-day average, and the old glucagon kit, which many of you recognize, and you'll remember that you had to mix a diluent with a solid tablet. And what we know about this older kit is that many people actually used it incorrectly, as high as 86% of the time. What's really exciting is thanks to JDRF's leadership, our investment in research, what has happened in my daughter's own type 1 diabetes journey is that the standard of care and technology has improved markedly. And I know this has impacted people in your chapters, your loved ones, and people across the type 1 diabetes spectrum, not just here in the United States, but increasingly globally. Look at this new tech, automated insulin delivery with algorithms that automatically dose, much significantly improved glucagon opportunities, and the ability to dose from your phone much more discreetly. And there's more to come, I think, in terms of technology, and that's on another RIV deck. But I just want to underline here that what do all of these advances have in common? Clinical trials. You heard from Janie Boodle and Aaron Turner-Pfeiffer last month, but we really need to get the word out about clinical trials. No one would have these devices or these new glucagon formulations if people before them, decades ago, or even just 10 years back, hadn't participated in clinical trials. So just giving a shout out to that work. But screening is the same. Screening and early detection of type 1 diabetes, and now our ability to delay the onset in some. So let's look back again to, I'll just follow the same timeline in 2002. The benefits of screening were still fairly unclear, although we were starting to build an evidentiary base for some of the benefits that I'm going to talk about in the next set of several slides. We were still really unable to predict which individuals would progress to insulin-dependent type 1 diabetes, and let's reflect on what Esther taught us today, stage 3 type 1 diabetes, where people need insulin, not stage 1 and stage 2, where we just see the autoimmune process in play in stage 1, and in stage 2, we see some dysglycemia or glucose levels that are out of range. And we did not have a therapy to delay onset, although JDRF was actively funding trials by Kevin Harold and the TrialNet group to look at teplizumab. What's going on today? Well, the benefits of screening are well described. I won't get into details here, but DKA prevention, time to plan and prepare. We can now predict individuals that are likely to progress, there are the words, to stage 3 or insulin requiring type 1 diabetes. We have described the staging, stages 1, 2, and 3, and this helps us in our design of clinical trials and in clinical trials designed to delay and prevent the diagnosis, not having to wait until somebody requires insulin. We have an approved therapy. The first since insulin in 1921, which was administered in 1922. And we've got multiple clinical trials underway to delay and prevent type 1 diabetes or explore that possibility. So this is really important. In just 20 years, the change we've seen in the screening and early detection space. But I put these little icons on this screen to remind myself to say that people out in the world, so that's the little group of people, and healthcare professionals in clinical practice today are not aware of today's knowledge base, today's evidentiary base, and how it should influence their clinical practice. So we've got a lot of work to do at JDRF, and we need your help. So let's just look quickly at the technology and see who's taking advantage of these newly available therapies. So if we think about continuous glucose monitoring, we've been working on them for the past 24 years. The Glucomander watch, which some of you will remember, came out around 1999, 2000. CGM have been in the clinical guidance very clearly since 2018. The clinical guidance today says everyone with type 1 diabetes should have a CGM at diagnosis, not wait 2 to 3 months. How many people are using CGM technology? We had a paper out in April of this year, less than 1 in 2, about 48%. Let's talk automated insulin delivery. We have so many options now. I got to see the new Mobi pump over 2 weekends ago. It's tiny. Things are getting smaller. Algorithms are getting better. We're getting interoperability around automated insulin delivery. It's been in the guidance for 6 years now, but in the real world, again, a publication from earlier this year, just a couple of months ago, only about 10% of people with type 1 diabetes using automated insulin delivery. We need to do more work to upskill clinicians in practice so that they can get these devices to people sooner. Is JDRF focusing on this right now? No, we may get our hands on it at some point, but in the meantime, let's focus on the cure side of the house. First of all, staging and screening. JDRF was instrumental in describing the staging in 2015 in a manuscript in Diabetes Care. That's why I've got the picture there. And in 2022, again, in the clinical guidelines, we saw a recommendation to screen people in the clinical setting for the first time out of research. This is exciting, but what's happening in the real world? We estimate that less than 1% of people eligible for screening in the real world setting, meaning in clinic, are actually getting screened in that setting. So we've got a lot of work to do. Why? 85% of the time, as Esther and Raquel shared, people don't have a family history. So we need to screen people not just who have a family history, but those that don't. And more than that, we need to screen people with a family history. We estimate that about 250,000 people have been screened through the research pipeline. There's probably 8 to 10 million first-degree relatives of people with type 1 diabetes in the United States, most of whom have not been screened. And then finally, the first therapy to delay the onset of type 1 diabetes, teplizumab, MZWV, or much more easily pronounced Tzield, the trade name. This went into the guidance in 2023. They actually had to change a chapter name from delay and prevention of type 2 diabetes to delay and prevention of diabetes. It's tremendously exciting, but very few people have availed themselves of that therapy. So we've got some work to do together. When we think about this new technology, when we think about staging and screening and therapies that are immune therapies, no longer just insulin and monitoring glucose, there has been an extraordinary increase in clinical complexity. I would just quickly draw your attention on the left to the 1989 standards of care in diabetes. They came out for the first time in 1989. They were 4 pages long with 10 citations. You could literally read the standards of care between clinic visits. Fast forward to the standards of care that came out just last month in January, over 300 pages, over 3,000 citations. And in the psychosocial section alone, there are over 50 recommendations that a clinician would need to implement. Simultaneously, clinic visits, especially in the adult space, are getting shorter and shorter and shorter and shorter, some down to 15 to 20 minutes. So there's more to do in less time. And this puts an extraordinary burden on our partners in clinical care. In the research setting, you've got a whole lot of time, but in the clinical world, as many of you know who visit clinic as a patient or somebody who is receiving care, there's not a lot of time with your provider. So we need to think about the clinical paradigm at JDRF. What do we need when we think about screening and staging and monitoring and early intervention, early detection? We need to make sure that clinicians out there and the general population is aware of this pivotal moment in type 1 diabetes, this changing clinical paradigm. Again, where we're not just thinking about type 1 diabetes as metabolic management. We measure your glucose, we give you insulin. No more. We can detect it early. We can intervene immunologically. We have therapies that are approved by the FDA to do so. And we've got a lot of clinical trials testing other opportunities in other therapeutics. So we need to make sure that people are aware of this change. It's an exciting time, but it's a really important time that we don't lose momentum. We also need to change clinical workflows. So as we educate and upskill in ourselves in the clinical setting, we need to make sure that workflows can accommodate screening and monitoring and these new therapies. Some of these therapies are going to require an infusion. That infusion center may need to be open on the weekends. How do we do that? But backing up, we've got to get people screened first, because if we don't screen, those therapies before insulin is required, before stage 3, are not even an option. And of course, we need healthcare professionals with up-to-date knowledge, improved competencies, and readiness to take on this work. This is new. And again, we talked about the clinical distress that many practices are under. We need to figure out how to seamlessly integrate this into that clinical workflow in a way that's actionable and feasible. And then I mentioned earlier, right-sized clinical workspaces. The clinical space I worked in for 14 years at the University of Florida, that building was built in 1990. The DCCT completed in 1993. That building wasn't even set up to download data from devices or to have telehealth visits. And now we are adding screening, staging, and early detection, and then therapy. So we've got some work to do in thinking about what does that medical home look like for type 1 diabetes. And then finally, particularly related to screening, people who are being screened don't have type 1 diabetes. All of the expertise around screening is in specialty care. It is in specialty care and pediatric, and in some cases, adult endocrinology. So we need to make sure that there's a diffusion of knowledge to primary care and a partnership with primary care where screening can take place, because we don't have the capacity in specialty care and endocrinology to screen the general population, and frankly, probably not even first-degree relatives, but we're going to give that a go. So let's move on. So what has JDRF done? JDRF has a new department. We roll up to Sanjay Dutta, our Chief Scientific Officer, and we have 3 sort of core areas that we're focused on. One is promoting early detection of type 1 diabetes with a very laser focus on screening and monitoring. We want to increase awareness, and we want to increase access to screening so we can achieve our other goals. You heard again from Janie Boodle last week. We want to create an inclusive culture of participation in research in the type 1 diabetes community. I've noted before on these calls that many of our cure-related clinical trials are not very diverse. In fact, the teplizumab pivotal trial was 97% non-Hispanic white. We need to change that picture. We need to make sure everybody is offered the opportunity to participate in research. And to do that, we need to make sure everybody is offered the opportunity to be screened. And then finally, we want to make sure that the information we share at JDRF reflects the current standards of care. So who are we? I'm in this department. I report directly to Sanjoy, and I've got this amazing new team. Julianne Lally is our associate director. She joined just at the end of January on the 29th. She's a physician's assistant. Janie Boodle, you've met. She's an RN and former clinical trial coordinator. And Kelly Aladina joins us from the Georgia and South Carolina chapter, but she is an RN CDCES and has experience in clinical practice in the Atlanta area. So what you'll note, what is in common is everybody has clinical practice experience on our team, and that's important as we go through the next set of slides. So again, we work on the clinical trial sides. I'm not going to address that, but what I want to talk about is what are some of our tactics to expand early detection of type 1 diabetes and our focus on screening. Well, we're doing some work with healthcare professionals. I'll say more about that, but we're doing some work in terms of diffusing knowledge to healthcare professionals in specialty and primary care. We are working with clinics directly to support innovation in clinical workflow to see if we cannot test the feasibility, like, can this work in primary care, the acceptability, will patients get screened or will people get screened in primary care, and can it happen in the clinical workflow? And then we want to see the efficacy. Can we identify people at risk and connect them to specialty care? We're doing a lot of work in the type 1 diabetes community at JDRF and more broadly to make sure that people walking out there in the world are aware of what type 1 diabetes is and that we can detect it early. We're doing some work in clinical guidelines to support our clinician colleagues. And finally, we're working on some more mass media. So rather than just person to person, we're working on some mass media to communicate these important messages. Let's talk about HCP education. To date, the team is new. We've been around just over 2 years, but really, as you've seen, we've added 2 people in the past 3 months. We have educated directly 2,000 healthcare professionals, meaning they have redeemed accredited healthcare education about screening and monitoring that was coordinated or provided by a JDRF staff member at clinical conferences. Our initial focus was on specialty conferences. We leaned on key opinion leaders around the world to deliver information about screening and monitoring and their importance in the clinical paradigm. But I've attended a lot of clinical conferences and redeemed a lot of accredited education on a variety of topics, but there is a disconnect when you go away to a conference in Atlanta or Los Angeles, and then you come back to your clinical practice and try to take action on the information you learned. So we will continue to do that work because, again, we want to make sure that there is a broad diffusion of knowledge about screening and monitoring, early detection, and related clinical trials. But we have pivoted to include and focus on primary care because, as I noted earlier, that's where a lot of screening needs to and eventually will take place. People who are screened don't yet have type 1 diabetes or aren't aware they are in an early stage. We are also providing accredited education directly to clinics, one clinic at a time. And these are clinics that we have a partnership that I'll talk about in a moment. Why? Because we can provide the knowledge and then they can, within the next week or two, sometimes the next day, put that knowledge into practice in their clinical setting by actually screening someone, getting the results, and taking action upon them. You're going to have the slides, so I'm not going to, you can pause the recording and look at the accredited education we are offering, but it ranges from diagnosis and classification of diabetes all the way through to some of the currently recruiting clinical trials and a lot of steps in between. Moving on. So I mentioned that we have pilot clinics. Yes, we do. In fact, we have 42 pilot clinics under contract with JDRF around the country. We are in discussions with others where we've identified a clinical champion to lead this work in that setting, and we've been approached by more, and those are the in-progress clinics. You can see pink are our contracted clinics, blues who we're about to sign an agreement, and the orange are people that were sort of in the early phases of discussion. What are we trying to do in these clinical pilots? We want to improve access to screening around the country, and we've got a lot of work to do. There's a lot of states that are missing pilots, but we want to improve access, and we want to improve access among people who are typically not represented in screening. We want more diversity. We want to demonstrate, as I noted, that it's feasible, that it can be done, that it's acceptable, that people want to do it, that they'll take advantage of it, and that it has efficacy, meaning we can identify people at risk and move them forward to treatment or clinical trials. Sorry, I wave my arms around a lot when I talk. I just realized I was doing that. Again, screening and monitoring in the clinical setting. And people also will have the opportunity, if they come up as positive, to avail themselves of research studies. So we want to connect people back. We want clinical workflows that we can generalize to other settings. There's been a lot of hard work done at these clinics. I'm going to share one story with you. But what's great is once it's done in a setting in one state, that can be replicated in others. So people don't have to reinvent the wheel. We also want to build that healthcare provider and staff capacity. And we need to get this in the scientific literature. We can't change the clinical guidelines if we don't have evidence that things work clinically. And so we are encouraging our partners in these pilots to publish and present at national and international conferences. So let's talk about one of our clinics. This is University Hospital. It was our first. There were two that started at the same time. The first was this large hospital in Newark, New Jersey. The other was a very small federally qualified health center in a small town of 900 in Idaho. So very different settings, but people in rural America and in large cities all need to have the opportunity to be screened. So we're looking at a lot of settings. What happened over the past 18 months in Newark, New Jersey? You can see on the left the clinical team. I'm delighted to share that they presented their efforts at a clinical conference in August of last year and are now working on a paper about their work. On the right, that very complex looking grid is their clinical workflow. How do I book the appointment? Who collects the sample? How do I send it in? What do I do with the results in the electronic health record? So lots of details. We are funding from the JDRF side a patient navigator. People cannot build a new clinical process during their lunch hour or at night or on the weekends. So we are funding somebody to support building this clinical process. We are subsidizing the cost of the assays. This is a safety net hospital. We are providing free healthcare provider education or healthcare professional education, as noted on the last slide. And we've helped to partner to create patient-facing materials in English and Spanish. What's happened? They've approached over 1,000 community members. Nearly 900, it might be 900 now, have been screened. More than 70% of people who've been screened identify as people of color, as Black Americans. And again, they've published their first paper. I can say that at this clinic, they have identified individuals who are autoantibody positive. and one of them had an elevated A1C and was in stage 2 type 1 diabetes. So we think we're moving toward efficacy. Let's talk now about, I'm moving on from pilots, happy to answer questions on the call. Let's talk about the community needs and knowledge about screening. So you RIVs are out there in your chapters, in your markets, educating. What we have found by polling attendees at Type 1 Nation summits around the country is that people need a lot more information about screening, and people who have a connection to type 1 diabetes need a lot more information about familial risk and about risk of progression. So on the left, this was a question about increased risk for type 1 diabetes if you're a family member. And as you know, family members have a 15 times, up to 15 times higher risk, especially first-degree relatives. In this group of 471 people, only 19 could accurately identify the increased risk. Most people didn't think there was any increased risk, indicated that they had no idea, or thought risk might be about 2 times higher. So there isn't a sense that family members might be more at risk, and many people, knowing there's more risk, might be more likely to screen. That's what we hear. Also, people are not sure what autoantibodies mean, and what we know is that if you have 2 or more persistent autoantibodies, your likelihood of progression to requiring insulin to a stage 3 diagnosis is nearly 100%. But again, people are not aware of this fact either. And we also polled, you may have received, these are responses from over 2,000 people, you may have received an email from JDRF asking you if you or your child has participated in screening. If you look at the bottom, the majority of people have not. And when we asked them why they hadn't, most people said they weren't aware that they could get screened, that type 1 could be detected early, and they wanted to get screened, but they didn't know how. So you are going to be instrumental in helping them find those pathways. We will continue on our team to provide education at Type 1 Nation events. This is where we went in 2023. This is where we're going in 2024. If you are in one of these communities, join us. If you have screened, come tell your story with us on stage or help us identify a family who can do that. We've talked to 3,000 people, staff, volunteers, and community members so far. And I will say that we all need to be sharing this message to amplify awareness and education. So thank you in advance for your partnership. Finally, when I started at JDRF 2 years ago, Sanjoy asked me, what are some of the barriers to increase screening in the clinical setting? Meaning, why aren't doctors and nurse practitioners and physician's assistants prescribing screening in the clinical care? And one of the things we identified was that there was nothing, zero, not a word in the clinical guidance about how to monitor somebody when they come back positive. I often say, I'm a nurse practitioner. I would be very wary to prescribe a lab where I did not have written guidance on what to do with the result. If someone comes back positive, I need a very clear process for what to do next to support them and to protect them from DKA and to make sure they get the support, both psychological and educational, and also clinical and medical support that they need. So a year ago in February, JDRF convened a group of experts. They were in 11 countries on 4 continents. We had 73 international experts, and you can look at the bottom of this slide. We have already had endorsements of a document to guide monitoring for people who are autoantibody positive but don't yet require insulin from ADCES, the Australian Diabetes Society, the European Society Association for the Study of Diabetes, the Endocrine Society, ACE, ISPAD, ATTD, and we are in conversations now with ADA. It's under review there. Hopefully this will come to print soon to guide that clinical care of people who are autoantibody positive and likely to progress to a stage 3 diagnosis. And then finally, we've got to spread the word more broadly. We are interviewing agencies right now who are going to help us spread the word in partnership with our fabulous Marcom team. But I can tell you, we've reached over 10 million people already. We can drive people to our website. If you look at the bottom left, when we advertise about screening, we make the T1 Detect webpage the #1 webpage on the JDRF site. We can drive people there. They spend about 6 minutes on the page. We are working on telling screening stories moving forward. And we want to talk about this paradigm shift in type 1 diabetes, and we want to talk about the heroes in type 1 diabetes research who screened, who participated in studies to delay and prevent type 1. There is a link at the bottom of these slides. I can say more about it, but if you have a great story about participating in screening or a clinical trial, please share your story at that link. So how can you support these efforts? Let's move through these slides quickly. First, share information about the benefits of screening at every opportunity. Don't leave it out. Talk about reduction of DKA at diagnosis. Talk about giving people the time to plan and prepare. And it's not just for taking insulin and monitoring glucose and changing the way you interact with your competitive sport or at work. It's also gives people time to consider if they don't enroll in a study before they're in stage 3 type 1 to give them time to think about, if I progress to a diagnosis of stage 3 type 1 diabetes, I want to do a study. I'll say more about that on a future slide. We need people to participate in stage 2 type 1 diabetes delay and prevention trials. And people should be referred when autoantibody positive to a specialist to consider FDA-approved therapies. Those are 4 extraordinary benefits. Share information about screening and monitoring at every opportunity. How do people do it? Research pathways and clinic-based screening. I'm going to say more about that on another slide, so I will not linger here. And please share information about clinical trials. We have got to raise our hands, step forward, and get off the sidelines in the way we feel comfortable, but we need the community to embrace research. So here are some things that you can share. A family history is a strong predictor of type 1 diabetes. Risk for family members, so parents, siblings, and children, is up to 15 times higher. So 1 in 20 if you have a first-degree relative. If you're out in the general population, 1 in 300. Now, some people, when I share this information, they get nervous. They feel fearful. But the truth is, folks, if people feel distressed, worried, or concerned, consider the following. If you're a first-degree relative, 95% of the time, you're going to get a negative result. 95% of the time, you will get a negative result if you're a first-degree relative. And if you're in the general population, 99% of the time. That's why we need to screen a lot of people. But my family has been screened. We have come back negative. And I will say, in my own experience, that has provided me with peace of mind. Moving forward, can screening and monitoring reduce DKA at diagnosis? The rate in the United States is about 50%. In rural states like South Dakota, it's 70%. But the truth is, we know from research JDRF has funded, we can reduce DKA at diagnosis all the way down to less than 3% in most studies. This is probably the most important passion point for me. My daughter was diagnosed in DKA in the ICU. I would love to be able to say that no other child or adult is in DKA at diagnosis. We can get close. We need to share this benefit. If we move on, share the word about clinical trials, recruiting right now. We have a study recruiting in stage 2 type 1 diabetes, the STOP T1D ATG study, but you got to screen to know if you're eligible. They're only recruiting folks in stage 2, ages 12 to 35. And then remember, new onset studies usually enroll, look here, in the first 3 months after diagnosis, the first 3 months. If you're in the ICU with your child like I was, or as an adult, that is not a good time to start thinking about research. So if you screen and you can see it coming and you have time to plan and prepare, there's a much higher likelihood that you will consider a research study at diagnosis. We need your help getting people to screen. So if they don't do or don't qualify for a stage 2 study, they consider a stage 3 new onset study. And then finally, we have an approved therapy. I don't think I need to say more about teplizumab or Tzield, but you cannot take Tzield right now unless you're in stage 2, and you cannot know you're in stage 2 unless you screen. Again, this is 8 years and older in stage 2 type 1 diabetes, 2 or more persistent autoantibodies with dysglycemia or abnormal glucose levels. You got to screen to know you're at risk to avail yourself of that. The other question we get all the time, how do I get screened? 3 columns on this slide. First, TrialNet. This is first-degree relatives, ages 2.5 to 45 years. Second-degree relatives, ages 2.5 to 20 years. You can visit a research center near you. You can order a kit in the mail. TrialNet will be at the Type 1 Nation events. They will be at our walks. Connect people to TrialNet. And what I just learned is starting in the summer, children under 17 and younger, so under 18, can rescreen every other year starting this summer. We also support a program called ASK from the Barbara Davis Center for Diabetes in Colorado. Any child, no connection to diabetes, can be screened for type 1 diabetes risk and celiac disease risk. This is a really excellent opportunity. You can order a kit in the mail if you're not in Colorado. Please visit their website. Got a little flag on this page. You can get there from www.jdrf.org T1 detect. We will link you to all these places. And anyone can get screened, although insurance is much more likely to cover family members, in the clinical setting. Blood will be collected by your care provider at your doctor's office. These are the autoantibodies that the doctor needs to order per the clinical guidance. If you're interested in clinical screening, get with our team. We'd like to support you and get your feedback on how it went, but we are meeting with a lot of success based on experiences in our own community. And finally, support. I said that 95% of people will come back negative, but 5% do come back positive. And that is stressful and can be anxiety inducing. And we need to make sure that we are providing support. This is a free service. Share it with people. See the check mark up there. Ask the experts. The URL is down at the bottom of the screen. If you're nervous about screening, these are experts that will talk to you about screening. If you've gotten a result and it's a positive result and you want to talk about what to do next, these experts will talk to you about that. If you've gotten a negative result for yourself or your child and you think you want to rescreen, they'll talk to you about that. And they'll talk to your primary care provider about how they can support you in this process or support people in our community. Check out this site, learn more, share the word. People should not receive these results and not have a place to turn for additional support. I want to say thank you. I'm excited to see you on the call. And thank you for your partnership in sharing the word about screening, about clinical trials. Esther, Raquel, the entire research department, and our department, and the rest of the JDRF organization are grateful. We will do this together in partnership with amazing volunteers like you. Thank you.